Thank you, Dr. Sugandha, for the wonderful presentation. Now I invite Dr. Nisha for the next talk. Preoperative marking is very important in a case of toric IOL. So we will see what all things to be done in a preoperative marking.
Good evening all. Now I'll be dealing with the preoperative marking of the toric IOL. So this is to ensure that we end up placing the IOL in the desired axis. The placement of axis of placement of IOL will depend upon the precise marking of the horizontal reference axis. So there are two markings, that is a reference marking, which is a pre-op procedure, and an axis marking, which is an intra-op procedure. The pre-op reference marking is placed at the limbus in three locations, that is 0, 180 degree and 90 degree, and the patient is in the sitting position. Axis marking is identify the optimal axis of IOL placement as determined by the toric calculator. Axis marks are placed on the eye using pre-op reference marks for alignment of instrument. And there is some amount of cyclotorsion in the eye when the patient moves up from an upright position to supine under the surgical microscope. And it can vary from 2 degree to 16 degree. Hence, it is important to mark the horizontal axis in the sitting position. So there are various methods, that is manual methods and automated methods. And the manual methods are by freehand marking, simple toric reference markers, anterior stromal puncture with staining, bubble marker, pendulum marker, and electronic toric IOL marker. And automated methods are by limbal registration, that is by Varian image guidance system and Callisto eye. Intraoperative, there is another method, it's an intraoperative wavefront aberrometry, that is by Aura system WaveTech Vision. Now coming to the freehand marking, by using a junction violet pen after topical anesthesia, when patient with both eyes open, fixation at a distant object, mark the limbus at 0 and 180 degree. Other prerequisites are, you can rest the hand on the patient's cheek to enhance the control of the marker. Check that the patient's head is not tilted left or right. Now take the marker below the eye and then move it up and straight towards the eye. The reference mark should be done on a dry eye, because a large mark from ink that smears or bleeds on the surface will cover a range of degrees, and it will compromise on the precision of the IOL alignment. And you can use speculum in cases of small papillary pictures and also in non-cooperative patients. And the prerequisites of the slip beam should be of size of 14 millimeter into 1 millimeter, and it should be oriented at 0 to 180 degree, and is focused on the corneal apex, identification of which was aided by the first Purkinje image. This Purkinje image will appear as a small cylindrical reflection of light bulb. Focusing at the center of Purkinje image ensures that centration of the slit beam. So this is the junction violet pen which we use, and it should be always sterile and pointed. Avoid the blunt tip. So this is a video demonstrating the freehand marking. Here the slit beam is oriented at 0 and 180 degree, and by using a junction violet pen, marking is done at 0 and 180 degree. So next is the anterior stromal puncture with staining. Here two methods can be used. That is, first is using a stain needle, 26 gauge needle. Anterior stromal puncture can be done at 0 and 180 degree just inside the limbus. Further, the patient is asked to blink for 2 or 3 times. Another method is here, there's a video demonstrating the other method. Here speculum is used, and after marking at 0 and 180 degree with the junction violet pen, um, 26 gauge needle is used to mark at the 0 and 180 degree. So this is the 26 gauge needle is used to again mark at 0 and 180 degree. And next method is by using a Cioni toric reference marker. This is an instrument which has a semicircle ring with 3 wedges at 0, 90 and 180 degree, and it has a handle attached to it. Now it can stain the wedges with the junction violet pen and now move towards the eye, and the wedges are placed on 0, 90 and 180 degree. So this is a video showing marking by bringing the wedges in contact at 0, 90 and 180 degree. So this is an image of the eye after marking, that is at, you can see at 0, 90 and 180 degree. This is a bubble marker instrument. So this is a video demonstrating. It has wedges and hemicircle ring with the wedges and a handle. There is a air bubble inside the liquid which moves to right and left on tilting, and when it is center, remains. When it is horizontal, the air bubble remains vertical to the center to the vertical line. So the method is by, like after topical anesthesia, the patient is seated in the upright position, fixed at a distant target. The markings are made at 3, 6 and 9 o'clock position. Now when the bubble is in the center of the vertical line, it is indicated that 3 and 9 wedges of the markers are truly horizontal. Gradually move towards the eye while the examiner ensures that the bubble is in the central position when the wedges make the contact with the limbus. So this is a video showing the bubble marking. So you can see the air bubble is in the center of the vertical line. Next is the pendulum marker. Yeah, this is an instrument where now the patient is asked to fixate on a distant target, and the 0, 90 and 180 degree contact wedges on a hemicircle of the device are attached to a shaft within a hollow handle to a gravity pendulum. This ensures that the wedges remain perfectly horizontal even if the handle is rotated either side. This is another instrument, that is an electronic toric marker. It marks the 3 and 9 position on the limbus. The electronic head is fitted on the body, and the marker is gradually moved towards the eye. It has a flat handle, so it ensures, it gives more stability while marking. And the green light indicates that horizontal wedges on the marker are truly horizontal. And the orange light with a slow beat indicates that it is slightly tilted. Red light with a fast beat shows that it has a severe tilt. Then other sources of errors are due to manual methods are smudging or fading of the eye. It can cause broad marking, and the mark can easily diffuse 10 degrees, or the mark may disappear entirely, and there's a Bell's phenomenon too. So to avoid these errors, there are automated methods. So the automated methods are by Varion digital marker, that it provides more information, like it gives automated centration, it gives an incision position, and you can avoid the pre-op marking, and also provide centration and alignment guidance for toric IOL. Thank you.
Thank you, Dr. Nisha, for that wonderful presentation on how to mark a toric IOL for toric.